Okay, start record. Good evening, everybody. Welcome to Abbott webinar. Today we are going to discuss something regarding fresh to frozen embryo transfer, a paradigm shift. This is my credentials. I am professor and HOD at Scientific Research Institute. I have got 113 publication at ORCID, and anybody want to see all my publication, just scan this QR code. We have got DNB seat at Surendranagar up to 2027, 53 resident already passed. We have got ICOG seat also, 16 book published by me and 61 paper, and today is my 763 presentation. How beautifully everything is arranged by Almighty. As soon as child enters this world, mother is ready to take care of it. The blessings of Mother of Mind and so many others, 3 books written by us, step by step male infertility, gynecological endoscopic surgery, and active management of labor is recognized as a reading material in Royal College. Atlas of Fetal Echocardiography and Technique of IVF Made Easy has gone for 2nd edition. And I am editor-in-chief of 2 journals, that is Indian Journal of Obstetrics and Gynecology. This is a Scopus journal, so anybody wants to publish their work, they can contact us. And also editor in Open Access Journal in Gynecology. Worked as a KOL in dydrogestone, and recently I got opportunity to interview Professor Herman Tourne in ESHRE 2023, Copenhagen. Today my talk has different sessions to follow. First we will talk what is infertility, assisted conception, focus on IVF. There is a shift from fresh to frozen. Nowadays everybody is talking about freeze all. Choosing between the day 3 versus day 5 transfer. Should we perform fresh embryo transfer? That is the now biggest question nowadays. What little support we have to give when we are giving the frozen embryo, and ultimately lastly little bit summary. Let us discuss what is infertility. We all know that 1 in 6 couple globally experience infertility at any stage in their lives. 17.5% global prevalence of lifetime infertility. If you talk about India, 10 to 15% of married couple in India are affected by infertility, and 27.5 million couple in India seeking infertility help nowadays. What is infertility? If we say by definition, it is a failure to conceive after 1 year of regular unprotected intercourse. Infertility can be result from so many factors or combination of factors. If you see there is a female factor, there is a male factor. In female, there is a tubal factor because of tubes are blocked, damaged, that impacts fertilization to the embryo transfer. Ovarian factor, it is inability of ovary to produce egg of desired size, particularly in the cases of polycystic ovarian disease that impacts ovarian oocyte production. There are so many structural and functional disorder of uterus, like there is uterine didelphys, unicornuate uterus, septate uterus, or there is endometriosis, or there is adenomyosis. This all affect the fertilization of embryo transfer. Male is 33% of contribution in infertility. Male has got low sperm count, or there is a hormonal deficiency, immunological problem, chromosomal abnormalities, serious illness, unexplained detectable causes. Recently we have got done debate in ISA 2024 at Rajkot that whether male are infertile or not. That debate you can see on this one is 4269 channel. Several causes or risk factors have been associated with infertility. In majority of the cases, male, female, or sometimes it can be a combined. 1/3 of infertility can be attributed to male factor, 1/3 that is of female, and 1/3 is from both. So if you give by percentage, by 33% is male, 33% is female, and 33% is combined. So if you see anyway, there is 66% of infertility nowadays. For those couple who have got infertility, we have got one very good option, that is assisted conception or ART. Let's focus on IVF. Outcome of clinical pregnancy resulting from IVF in 2020 in United States. Over the last decade, the percentage of live birth deliveries from ART cycle increases among the old age group. You can see that 82% of clinical pregnancy from ART cycle started in 2020 resulting in live birth. These all are the single birth, because nowadays we have got single embryo transfer norms. Multiple pregnancy is very reduced, 5.3%. Still there is high scope of miscarriage, that is 15.17%, and 0.5% is gone for stillbirth when fetus commits suicide. We all know that Lewis Brown, born in 1978, and revolutionized the infertility area. We have to thank Professor Edward and Steptoe, who has given us the norms of in vitro fertilization. Even though it was a fertilization through a laparoscopic ovum pickup and fertilization by her husband's sperm, and they transferred day to embryo into the Louis Brown's mother, and now she is coming in each and every X-ray to represent the first live born baby of IVF, 1978. Till date, more than 10 million babies have been born worldwide. If you see in India, the trends of IVF is increasing, and every day we are seeing that one or two IVF centers are coming up in every each and corner of India. But nowadays, to prevent the multiple transfer or multiple pregnancy, we are shifting from 2 to 3 embryo transfer to single embryo transfer. That's why again there is shift of fresh to frozen embryo transfer, and so many centers they are doing only frozen embryo transfer. So there is a very big shift from fresh to frozen embryo transfer. Why there is shift? Because if you see the number of ART cycle, egg collection source in United States from 2021 to 2020, that is a 10-year consensus. The number of cycle performed using frozen patient is increased drastically between these 10 years. You can see that this yellow line shows the frozen egg, and if you see the yellow line, frozen egg transfer is increasing, frozen egg transfer is increasing, and fresh embryo transfer is decreasing. Why this is happening to world? Because everybody do not want ovarian hyperstimulation. There is a very big endometrial embryo asynchronicity associated with breast transfer. You see, you have done controlled ovarian hyperstimulation. We all know that each ovum is delivering 100 to 150 picogram of estradiol that make endometrium little bit spastic. We are also giving LH surge that not be in our control, so they are making very improper implantation endometrium. We can say that a pregnancy conducive endometrium, but that endometrium is not that much conclusive, or that endometrium is not that much receptive. If you see the triangle between the implantation, conception and fertilization, and the lastly the embryo is implanted into the uterine endometrium, these all are asynchronous into this fresh embryo transfer. And there is also progesterone elevation during late follicular phase, because all this is a natural with exogenous progesterone and hormones from outside. So you don't have that much of control in this type of situation when you are doing fresh embryo transfer. When science evolves, we all know that frozen transfer are very good, and we can have all hormonal control in our hand. So because of the impaired endometrial receptivity in fresh embryo transfer, clinical pregnancy rate, if you see in frozen cycle, it is 84% compared to fresh cycle 54%. Implantation rate 70.8% in frozen cycle compared to 30.8% in fresh cycle, and ongoing pregnancy is also with very rise 78% in fresh cycle. And this all data coming in Fertility Study 2011, that impaired endometrial receptivity in fresh embryo transfer cycle after ovarian stimulation apparently accounts for most implantation failure in the fresh embryo group. So there is a need for frozen embryo transfer. Biological possible hypotheses are controlled ovarian hyperstimulation that we are giving, that will give rise to supraphysiological hormonal levels, may cause impaired endometrial receptivity, as already told, because every follicle is releasing 100 to 150 picogram of estradiol, and they are making endometrium little bit spastic. Even though if there is more than 15 follicle on each ovary, there are chances of ovarian hyperstimulation. But in the same patient, if you transfer frozen thawed embryo, you can transfer in subsequent unstimulated cycle, There is no C controlled ovarian hyperstimulation, so no disturbances in endometrial receptivity, no stimulation, so there is no risk of ovarian hyperstimulation syndrome. So latest nowadays people are doing freeze all, that is the new norm in 2023 in IVF center worldwide. What is the advent of frozen embryo transfer? Frozen embryo now account for more than 1/3 of all IVF cycles because of the evolution of cryopreservation. Previously, we are doing slow freezing, it is taking time. Nowadays, with vitrification, it is very easy to freeze and thaw. Freeze within 15 minutes, thaw within 10 minutes. You can have a very good cryopreserve media is available with different companies, and they are making our embryos safe in liquid nitrogen. There is also improvement in the stimulation protocol because nowadays we don't want any OHSS. So every clinic is now OHSS free clinic. There is inevitable increase in the genetic screening because people are doing PGD. Nobody wants that. They want single baby, and that baby should be devoid of any genetic disease. So they are going for PGD. There are data on perinatal and obstetrical outcome towards safer mother and offsprings. Common protocol for transfer of frozen thread, people are doing in natural cycle. That is a new norm, natural cycle IVF transfer in frozen cycle. You can modify cycle by HCG trigger because if there is one or two follicle, they may hamper the LH trigger. So you can give HCG, then give luteal phase support. You can have some stimulation cycle with clomiphene citrate, retrozole, or some gonadotropin to have a little good. If there is no good endometrium, you can make very good endometrium. And artificial cycle and ovary is totally suppressed with GnRH analogs. You can give exogenous estradiol and progesterone. Now everything in your hand, how much dose of estradiol, how much progesterone you want to give, the way on the day you want to transfer, day 3 or day 5, you can start progesterone and you can make progesterone conducive or pregnancy conducive endometrium. So in clinical practice, the artificial program cycle is popular because it involves less monitoring and embryo transfer can be scheduled on the day convenient to the UN patient. So you can have a Sunday drop practice, and it is well depended that now you can have a programmed IVF transfer also. Otherwise, once you are starting IVF, you are stuck with every day because you don't know on which day she is coming, which will be the first day, and on which day there is the transfer. So you can schedule your transfer in this frozen thawed cycle because you can fix the day of transfer on which you want to have a day 3 or day 5 transfer, and that cannot be on Saturday Sunday, so you can enjoy your Saturday and Sunday vacation. So freeze all, new no. Use of GnRH agonist protocol. You can use GnRH antagonist protocol also. Electively cryopreserve all the embryos and vitrification, and FET in subsequent cycle. So there is no fresh transfer. You stimulate the patient, do pick up, make good embryo, day 3 or day 5, freeze them and transfer at your convenience and at your ease. So that's why you are reducing the risk of ovarian hyperstimulation syndrome, because incidence of ovarian hyperstimulation syndrome varies from 3.1 to 6% of IVF cycle because of the exaggerated ovarian response to the gonadotropin stimulation. GnRH antagonist protocol, it is of shorter duration, less side effect and lower risk. Same like agonist trigger, because now you don't want to go for transfer, so you don't want to have a HCG effect, you don't want to have an effect of luteinization. So it will be a very good replacement of HCG trigger. It will rescue your luteal support, and you can transfer the embryo frozen cycle in subsequent cycle. So you can optimize the ovarian stimulation protocol, and you can get all the facility of reducing the OHSS. Frozen embryo transfer for specific IVF population. Particularly once we talking about polycystic ovarian disease, we all know PCOS we have very badly because it is a very erratic response to your gonadotropins. So among infertile women with PCOS, FET was associated with high rate of live birth, and lower risk of OHSS after the first transfer with fresh embryo. PGD is nowadays increasing. A patient with PGD for aneuploidy, ongoing pregnancy rate and live birth rate will significantly higher in frozen group because we are doing pregenital counseling and pre-genetic testing for all those couple, because IVF patient doesn't come on the age of 21. They usually coming at the age of 35, 40. So in this, all this patient trisomy 21, 28, trisomy 18, all genetic disease component will be there. So we can give them the option of PGD on frozen our gametes, because we can have a gamete single nucleotide, or SNP also we can do. We can also do trophoblastic biopsy. So from blastocyst we can take little bit of trophoblastic tissue and we can go for PGD. So freeze all is beneficial in very high responders, particularly in PCOS cases. There is a very good retrospective study done on single embryo transfer and live birth in 2018, and this is published in SART data, that is Society of Assisted Reproduction, and more than 82,000 pregnancies. They all know that they have got more than high responders with more than 15 embryo per cycle. But if you see clinical pregnancy rate in frozen cycle is 61% compared to fresh 57. If you see the live birth rate, is it 52% compared to frozen fresh embryo, it is 48%. So 2 to 3% increases with that, and there is less chances of OHSS. So freeze all with FPT cycle has got little bit higher pregnancy rate compared to fresh transfer in high responders. Now debate about the choose day 3 versus day 5 embryo transfer, that is individualized, and we have got lots of paper saying about the time of embryo transfer. There are several options. This is paper of 2023. You can see there is a paper of 2023. Several options have been proposed to increase the success rate of ART, such as prolonging embryo culture, that is day 5. Human embryo are usually transferred on day 3 or day 5, that is a blastocyst. Prolonging embryo culture may increase the success rate of ART, because we know that we usually transfer ourselves at the level of blastocyst, because ovum is resting in the garden of ampulla waiting for handsome sperm. Then 2 cell, 4 cell, 8 cell, 16 cell, 32 cell, that is morula. This all will be done in the tube. We have our tube is throwing the embryo into the ocean of endometrium at the level of blastocyst. So endometrium is usually ready with the blastocyst. So if you put blastocyst, sorry, the success rate will be high. So embryo implant in the uterus at blastocyst stage naturally and extend an embryo culture until day 5 could lead to embryo selection and has a very good demonstrable good outcome. Sorry. So what does evidence say? Rao in 2021. He said that this paper was published in 2021 by Rao and it is published in JINPEC, the Journal of International Medical Research. No significant difference in the biochemical pregnancy rate or ongoing pregnancy rate between the day 3 cleavage stage embryo and day 5 single stage embryo. There is a significantly higher rate compared with those who have got day 6 transfer group. Day 5 versus day 6, Cochrane in 2022. Significant difference in live rates from fresh cycle in favor of blastocyst stage transfer compared to cleavage stage transfer. Papanicolo in 2008, they had done systematical review which reports that cycle where equal number of embryos were transferred has higher live rates in blastocyst stage transfer than cleavage stage. Wang in 2014 says that similar rate with live birth rates but reported lower miscarriage rate in blastocyst group. So everywhere it suggests that if you do blastocyst transfer, it's very good. Then comes SCT, single embryo transfer. Elective single embryo transfer is procedure in which one embryo selected from a larger number of available embryos is placed in uterus or the fallopian tubes. But nowadays we are not doing gift at all. Multiple birth, we all know there is health risk problem. babies are coming IUGR, there are early chances of abortion, late miscarriage, there are chances of premature delivery, gestational diabetes, stillbirth, neonatal and maternal death. In recent years, we have seen that there is continued rise with multiple death has fallen, multiple birth rate has fallen because of single embryo transfer. Blastocyst transfer have been increasingly used in UK, also in India, and we are doing all transfer at the maximum implantation potential point, that is MIP point with SCT, single embryo transfer. And there is very good chapter in my book, The Technique of IVF Made Easy, that every uterus has got different MIP points. If you see, this is a uterus, normal uterus, and these both are the tubes in which they meet in the center, because we are throwing ourselves into the ocean of endometrium. So for this is for normal uterus. Suppose there is a bicornuate uterus and tubes are lying here. So if these tubes are lying here, the MIP point will be little bit down. Same way, particularly in the unicornuate uterus, only single tube is there, and that single tube transfer will be here. There is a subseptate uterus. This is a subseptate uterus, and tubes are lying here. You can have both these tube coming here. So every uterus has got different MIP point, that is maximum implantation potential point. And if you put your embryo at this MIP point with single embryo transfer, success rate will be very high. And this is not me saying, Papanicolo, Blake and Jett, they have produced in their literature that good prognosis after the age of more less than 35, not more than one embryo quality transfer, first and second cycle, previous successful IVF, or recipient of egg donors, they all have got very good chances of single embryo transfer. These all are the indications, and you have to put at the maximum implantation potential point. Then question arises, if there is no difference between the frozen and fresh, should we continue to perform fresh embryo transfer? Yes, we can continue in selective number of patients, because there are studies. In 2050, Rock, M and et al. Said that FETR associated with increased implantation rate, CPR and ongoing pregnancy rate. But the difference in implantation rate and ongoing pregnancy rate are being driven by higher responders with 10 to 15 oocyte receptors. They're done in two groups, 4 to 9 oocytes and 10 to 15 oocytes. If you see, they are done in 4 to 9 oocyte, FET 21%, but in group 2, 30.1% with high pregnancy rate in the patient. Those who have got very good number of oocytes are there. So patient with poor ovarian response does not get benefit from freeze all strategy. So those who have got 4 to 9 oocytes, endometrium is very good. You can transfer in fresh cycle also. So fresh embryo transfer is very much useful, particularly in low responders. Again, SARS has done study, and they done study on more than 82,000 pregnancy. They done study on low and intermediate responders. Low is 1 to 5 oocytes, and intermediate is up to 14 oocytes. If you see clinical pregnancy rate, FET versus fresh, you can see in fresh transfer 49%, 41%, 33%, 22%. These all are the FET. You can see FET is decreasing. So in intermediate and low responders, clinical pregnancy and live birth rate were higher in fresh transfer compared to FET cycles. And this is naturally proven. If you have got more than 15 oocytes, again I am repeating, all these oocytes are releasing more than 100 to 150 picogram of estradiol. They are making endometrium not receptive. But your oocyte is 4, 5 or 6. They are giving normal number of normal level of estradiol, and endometrium is very good. So you can able to do transfer in these low responders. Don't waste the cycle. If there is high responder is there, if you are fearing of OHSS, then you can go for all this frozen transfer. Then question arises, what should be given as a luteal phase support in IVF? Because we all know that luteal phase is utmost important in all IVF cycles. Because when we are doing pickup, we are not only picking the ovum, we are also picking the granulosa cell. And what is the granulosa cell? Granulosa cell are the mother of corpus luteum. And what corpus luteum secretes? Progesterone. Why progesterone is required? Because progesterone, name itself suggests, It is pro for gestation. We have to thank our mother that our mother has generated enough amount of progesterone in utero, so we don't have to require any luteal phase support. But if this corpus luteum is deficient, there will be insufficient corpus luteum. So insufficient progesterone available for nurture. So we have to give progesterone support in all IVF cycles. There are lots of options for the luteal phase support in IVF. There are many protocols for IVF cycles. Luteal phase support with progesterone, standard protocol approach for IVF cycle. Luteal phase support with HCG causes high risk. Luteal phase support with GnRH analogs and premature LH surge. The route of progesterone administration influences the treatment. What is convenient? It can be a transdermal, subcutaneous, intramuscular, intravaginal, and nowadays oral. Transdermal, we require large doses because 5-alpha reductase enzyme reduction for it is good for abort. It reduces absorption and it is not available at the proper site. Subcutaneous, we can give intramuscular and intravaginal progesterone. Intramuscular till day people are using, gestone people are using micronized progesterone. Every day you have to give or alternate day, patient is inconvenienced and allergic reactions will be there. Intravaginal, very widely practiced, preferred option. There are lots of paper for vaginal presentation of 400 microgram of micronized progestation. Orally, people are also prescribing micronized, but dydrogesterone is recently recommended by ASHRAE use. If we see micronized progesterone and dydrogesterone, both are derived from the same plant source, that is Discoria villosa. If you go for micronization, that will be a micronized progesterone, and if you are going for band breaking, either by chemical, electrical, or mechanical, then it becomes retroprogesterone and it becomes dydrogesterone. So women prefer over oral population because every time worldwide, if you say anybody, if you give oral, they are more confident, more patient friendly, patients are more satisfied. So 95% want to use oral dydrogesterone with 73% with micronized vaginal progesterone. There are multiple international guidelines. They are recommending the use of progesterone and dydrogesterone as a luteal phase support. If you see, this is a word by European Society that progesterone is recommended for luteal phase support after IVF and ICSI. Dydrogesterone is probably recommended for luteal phase support. It is 2019 by ASHRAE. Royal Australian and New Zealand Society, luteal phase support with synthetic progesterone should be provided in IVF. It is associated with improved live birth. Ministry of Health, Russian Federation in 2019, dydrogesterone and vaginal micronized progesterone has got the same level of efficacy. So once we had done study of Lotus 1 and Lotus 2, we had tried to prove that dydrogesterone is non-inferior. We are not saying it is superior, but it is non-inferior to micronized vaginal progesterone, and Russian Society says it gives the same level of efficacy. Society of Reproductive Medicine in China in 2019, you can see it is all the reports of 2018 and 2019. There is no statistical differences in live birth, clinical pregnancy rate, ongoing pregnancy rate, miscarriage rate, and multiple pregnancy rate for various luteal phase support approaches, that is either intramuscular, vaginal, or oral progesterone. So luteal phase support should be essential in IVF. There is need for luteal phase support in IVF because they counter any luteal insufficiency because of GnRH antagonist or agonist therapy. Because we had hypophytized the pituitary. Pituitary is the master orchestra. It will give stimulation to the hypothalamus. Hypothalamus gives stimulation to the ovary and uterus. There is pituitary, hypothalamus, ovarian, uterine axis. It corrects the abnormal luteal phase function and progesterone secretion. It also strengthens the endometrium maturation and receptivity. So if you give progesterone as a support, it not only make the endometrial pregnancy conducive, they also increases the activity of alpha V, beta 3 integrins. There is very good formation of pinopores at the level of endometrium, and also endometrium has got affinity for developing the endometrial glue or increasing the potential of osteoblast, or this hormone that will adhere to the endometrium, and they will ready for implantation. So any implantation and early development fertilized ovum is also decreased, so there is a very good need of luteal phase support. Progesterone suppresses the deleterious maternal immune response. We all know that when our body has got any antigen, there is a formation of Th1 and Th2 cytokines. That is the natural immune response. And thanks to COVID had teach us what is there is antigen and antibody. So in response to antigen, there is activation of Th1 cytokines, which is harmful, which will make embryo abort. But if there is activation of Th2 cytokines, it has got all protective cytokines, it has got immunomodulation, there is asymmetric antigen antibody reaction, and there is decrease in the natural killer cell as well as increase in the PIBF, progesterone induced blocking factor. This all will be done by progesterone, and it is modulated by Th1 and Th2 cytokines. It suppresses the T reaction, natural killer reaction, and synergetic action with prostaglandin. It prevents the abortion. In 1999, a very good paper published by Clark and et al. Suggested that why your mother has rejected you. And that paper has very good importance because they had done study on all the babies. Everything is fine, and suddenly you see that the embryo is not developing proper, or there is a early miscarriage, or fetal heart stops. They say that it is because of the immunomodulation, or it says that it is uterus' own desire whether uterus want to continue or discontinue the pregnancy. So role of progesterone is very much required in luteal phase support. 89% of increased clinical pregnancy rate, it's 77% increase in live weight with progesterone compared to placebo. And we have to thank Professor Sashaya and Professor Griesinger, those who have done very good study. There is a very good promise study, and there is a very good study by Griesinger. It says that luteal phase support with exogenous progesterone improves clinical pregnancy rate, live birth rate, and ongoing pregnancy rate. So again, there are different routes for administration. We can say the transdermal, subcutaneous, intramuscular, intravaginal, but dydrogesterone, that is 85.9% of women responded, and they would prefer the oral route of progesterone, that is a dydrogesterone. It is confirmed by all different societies. So oral dydrogesterone, it right progesterone for luteal phase support. Why? Because it does not suppress the pituitary gonadal axis. It is easily available at 10, starting with 10 milligram dose, and you can increase up to 40 milligram in transfer cycle. It has got least side effect, and hence the minimized adverse effect of progesterone. It gives immunomodulation because it increases the production of PIBF, that is progesterone inducing blocking factor. So oral route is preferred by majority of women because they find this route of administration is most convenient. And you can say that I am happy to say that this paper is written by Pandya MR in Indian Journal of Obstetrics and Gynecology in 2016, supported by Griesinger paper in 2019 and Ganesh's paper in Fertility Sterility in 2011. So this all is published by 2016 paper of Dr. Manish Pandya et al. In Indian Journal of Obstetrics and Gynecology. There is multiple international guidelines recommending progesterone support. This we had seen that there is no clinical significance. So there is evidence of dydrogesterone on fresh embryo transfer. This I am saying Lotus 1 and Lotus 2. First time, Lotus 1 is a double-blind, double-dummy study with 2 arms. Double-blind means even investigator doesn't know, patient doesn't know. They had made placebo of vaginal and placebo of oral dydrogesterone. Both are given to the patients. They had done study on more than 1031 patients, 974 embryo transfer. It is done on more than 38 centers worldwide, and they have got very good results. Lotus 2, it is an open label because we cannot make placebo of gel. So it is comparison of micronized gel, that is crinone or anything or sustained gel, with dydrogesterone versus micronized vaginal progesterone. More than 1034 patients, 900 embryo transfer, and India is one of the proud country in 37 centers with 10 countries. And what they found in Lotus 1, dydrogesterone 10 milligram TID, micronized vaginal capsule 600 milligram, that is 200 milligram TID, plus given oral placebo and vaginal placebo. Lotus 2, dydrogesterone 30 with 8% of crinone gel, that is 90 milligram once daily. If you see this cycle treatment on day 14 oocyte retrieval, either they are done on day 3 or day 6 embryo transfer, pregnancy day does on day 10, and ultrasound, first transvaginal ultrasound C for the gestational sac inside the uterine cavity was done on day 71 post transfer. So this is a 10-week duration, and you can see the result that with dydrogesterone group 187 compared to 158 of micronized, while in Lotus 2 191 compared to 171. So this paper suggests that dydrogesterone is non-inferior with the micronized vaginal progesterone gel at 12 weeks of gestation, because we all know that after 12 weeks placenta is giving very good amount of progesterone, so exogenous progesterone is not required. There is a meta-analysis of Lotus 1 and Lotus 2 that individual patient data analysis is more reliable than aggregating data. So aggregating data, the data study, the combined result, and the individual patient data, they uses the summary of data found in population studies, and they got the benefit that these data are more reliable and giving more detailed analysis. What the detailed analysis? Dydrogesterone associated with significantly higher ongoing pregnancy rate, live birth rate compared to micronized vaginal progesterone. This is ongoing pregnancy rate 381, live birth 345, with micronized is 341 and 312. So if you see the order ratio with dydrogesterone versus micronized, it is 1.32 and 1.28. With confidential interval is 1.08 to 1.4, with p-value non-significant. If you see this is graph, you can see it favors. If you see it is a 0, it both favors dydrogesterone compared to micronized vaginal progesterone. So they proven that with individual data, ongoing pregnancy and live birth rate are very good with Lotus 1 and Lotus 2. So luteal phase support is essential in all fresh transfers, because these are Lotus 1 and Lotus 2 is not of frozen cycle, but now we are talking about all frozen cycle. So luteal phase support is utmost important in frozen cycle also. Frozen cycle, inevitable dependence on exogenous progesterone, because we are making endometrium, we are giving them progesterone support. With our progesterone, we are making very good pregnancy conducive endometrium. So frozen cycle, no ovulation, there is absence of corpus luteum, no exogenous source of endometrium. So endometrial changes necessary for implantation and early pregnancy are totally dependent upon the exogenous progesterone we are giving. Extensively luteal phase support is at most significant in artificial cycle, because there is absence of corpus luteum. So what is evidence of uses of dydrogesterone in frozen embryo cycle? There is a very good comparison between the dydrogesterone intramuscular and vaginal progesterone supplementation in luteal phase support in artificial cycle. This study was done in 2016 by Rashidi BH. They had done comparison of clinical efficacy of oral dydrogesterone with vaginal intramuscular progesterone for luteal phase support in artificial cycle. They have done study on more than 180 patients. They are divided in 3 groups. One group has taken progesterone intramuscular. One group has got 20 milligram of dydrogesterone, and another group has got 400 milligram of vaginal suppositories. There is a very good research that comparing the pregnancy and live birth rate in all these 3 groups has got p-value of 0.46 and 0.37 respectively. Miscarriage rate was not associated difference in all these groups. or resulting pregnancy for each group were intrauterine. So there is no ectopic pregnancy. What is the assessment of this artificial cycle using dydrogesterone in luteal phase? Cumulative clinical pregnancy rate with dydrogesterone is 36.7 percentage compared with micronized progesterone 35.3. So oral dydrogesterone 30 milligram was associated with civil pregnancy rate of 800 milligram of micronized vaginal progesterone. So oral dydrogesterone may be preferred over micronized vaginal progesterone, particularly in artificial cycle with prolonged administration. That is confirmed by Al-Ahmad in ASHRAE 2019 poster was there. There is the first systematic review of meta-analysis of oral dydrogesterone in FET, and this paper is published by Patki et al. In Journal of Fertility and Sterility in the World in 2023. There is the 8 artificial meta-analysis, 5 randomized control trial and 3 retrospective trials in 2014 by Yang, 2016 by Rasidi, 2017 by Zari, 2012 by Ozair, Altmos in 2021, Gulo, Mario and Kubu in 2022. They all said the population is more than 3051. They had given progesterone gel in 960 and intramuscular injection in 1484 patients. These all are the pooled data from both randomized control trial and observation studies in FET showed that clinical pregnancy rate, live rate and miscarriage did not differ significantly between oral dydrogesterone and micronized vaginal progesterone with injection group. There is significantly higher satisfaction score with oral dydrogesterone compared to vaginal progesterone. Fewer side effects demonstrated on non-inferiority in clinical outcome of oral dydrogesterone. Better option than vaginal progesterone in intramuscular injection for patient with luteal phase support in women undergoing FET procedure for IVF. So if you compare dydrogesterone and micronized progesterone for luteal phase support in modified cycle, this paper was published by Ozer et al. In the year 2021. And there is a randomized control trial and they had given oral dydrogesterone versus micronized vaginal gel for FET cycle. Oral dydrogesterone 10 milligram TID, that is 30, and crinone gel or the progesterone gel is 8% 90 milligram OD. They said that oral dydrogesterone has got 71.6% of pregnancy compared with 68.7 by micronized vaginal gel. And patient, if you see the patient tolerability, it's very high, or patient significance, a significant higher patient score. First time this study has got very good p-value is very significant for the patient satisfaction score because it was an oral presentation or oral progesterone. Oral dydrogesterone provides an effective and easy way for the option of natural micronized progesterone in FET cycle compared to MVP gels. Has got similar pregnancy ongoing rate with fewer intolerable side effects. So optimal route for support for IVF FET cycle is oral dydrogesterone. This is another study by Pakabu and there is a pilot randomized control trial with 3 different groups of oral dydrogesterone, vaginal progesterone, and intramuscular injection. Total number of patients are there in dydrogesterone was 52, 55 and 44. If you see pregnancy rate, ongoing pregnancy rate is 21%. Patient with least moderate side effect is only 1 compared to intramuscular injection or side effect of 13. P-value is very good. So the treatment with 40 milligram, here the dose is high, 40 milligram per day oral dydrogesterone, 180, double the dose of progesterone gel or 100 milligram of intramuscular injection revealed similar effect outcome compared to FET cycle. Oral administration is best tolerated and showed a lower side effect profile per patient when compared to other arms. Another study by Wong et al. Compared the effectiveness of combined micronized vaginal progesterone, oral dydrogesterone versus micronized vaginal progesterone as a luteal phase support in FET cycle. This study was published in 2021. In control group, they have got 632 patients. Interventional group, more than 700 patients. They are given micronized vaginal progesterone compared with micronized vaginal progesterone and oral dydrogesterone 10 milligram BD. If you see the outcome, progesterone group has 41% of live birth, progesterone plus digogestrone. So now they are telling that if you give digogestrone and micronized vaginal progesterone both together, they will take care more and you will get the more result. This in India, we are doing years together, we are giving micronized vaginal progesterone vaginally and we are giving digogestrone orally and we are getting very good result. So in summary, you have to choose the right digogestrone. This is again paper by Pandya et al. It says that what is the recommendation? The women who have got more less than 35 nanogram of progesterone are 23 times higher to get experience miscarriage. This is recommended by Araben et al. That oral progesterone, namely digogestrone, are very well tolerated and effectively reduces the miscarriage in the woman at the risk of recurrent pregnancy. Progesterone therapy, especially digogestrone, effectively in preventing miscarriage in pregnant women with controlled group. So, the role of oral digogestrone in pregnancy, it will not suppress the gonadal axis, it help circumvent the inconvenience discomfort with intramuscular injection, high bioavailable, it causes endometrial transformation at the dose of 10 to 20 gram lower, because if you want to use micronized, you have to use 400. If you want to use digogestrone, you have to give 10 to 14, so very low dose. So minimum side effect of adverse effect on liver, highly selective for progesterone receptor because it will increases the PIBF, and this is paper published by Pandya MR et al. This is paper I am talking about. This paper is also published in Open Access Journal in Gynecology. So in this paper we had studied all this paper available in digogestrone. This paper was published in 2016. 27 original studies were there, that is a review article, and we have found the result that progesterone used for uterine phase support in assisted reproduction technology is associated with significantly higher rate of live birth or ongoing pregnancy than placebo or no treatment. Based on finding from randomized control trial and meta-analysis, similar ongoing pregnancy and miscarriage rate have been observed for digogestrone, that is oral, when compared to intravaginal micronized progesterone and between micronized progesterone intravaginal and micronized progesterone intramuscular for luteal phase support. However, digogestrone oral exhibits an overall higher ongoing pregnancy rate compared to micronized progesterone, the 30 versus 11%, and there is no evidence of indicate that maternal exposure to progesterone during pregnancy with increased risk of birth defect. So in conclusion, the relative effectiveness, safety, optimal route and duration of oral, vaginal and intramuscular progesterone for the topic of ongoing debate, future investigation with no longer follow-ups. So we say that digogestrone is utmost important and it is very good. In conclusion, we said that in IUI, you can give digogestrone, it will give 85% of pregnancy rate. If you use in IVF, micronized progesterone not as effective as intravaginal or intramuscular injection comparing luteal phase support. Oral digogestrone showed similar pregnancy and miscarriage rate when compared with intravaginal micronized progesterone as a luteal phase support in IVF cycle. Intravaginal progesterone can be considered as a viable option to IM progesterone injection. There is no serious adverse effect or congenital anomaly was observed when baby born with digogestrone. So innovator digogestrone, which has got very rich legacy of 60 years, because first digogestrone was used in 1961, before the 9 years I born. So it is a right choice. It is only available at VIPS in Netherlands. It has got digogestrone has got retroprogesterone structure. International birth of digogestrone I saw it in 1960. It is available in more than 110 countries. It produced only at the Netherlands in VIPS facility. In Indian pharmacopoeia, if you see, the drug has got permissible effect of 6-dihydrogestrone is less than 20. European it is 0.50, but digogestrone abort has got below 0.05 limit of quantification. So purity is the key parameter to ensure the product safety. Abbott dydrogesterone has got similar stringent quality standard as compared to both Indian and European criteria, and this makes the Abbott dydrogesterone world number one dydrogesterone with high purity and standards. They have got sustainability certificate. Abbott has got been awarded with sustainability certificate by European Pharmacia, and more than 600 papers. Out of 600, one paper is mine in 2016. Generic dydrogesterone has got no paper and lack of published evidence. We have got lots of evidence on dydrogesterone of Abbott. So to the dydrogesterone, which is backed by more than 63 years of legacy, exposure to more than 2 crore pregnancies, more than 100 crore tablets manufactured annually at only one place, that is Vips in Netherlands, and same dydrogesterone available more than 100 countries. In critical indications like threatened miscarriage, we know that 40 mg is the starting dose, then 20 mg BD still bleeding stops. Recurrent pregnancy loss, 20 mg BD, my presentation are there, 20 till 20. In luteal phase support ART, you have to give 30. In frozen cycles, we have to give 40. So use innovator dydrogesterone in all these cases. And I am happy to be there at Vips twice to visit the factory with all these Abbott people. So in summary, addressing luteal phase defect is crucial for infertility management, where progesterone supplementation plays a key role. In ART, choice of fresh to frozen transfer is important, that governs the postology of progesterone. APT has been found advantageous with respect to pregnancy outcome, with reduction in OHSS and reduction in the number of miscarriage. APT is beneficial in high responders. Optimum period of initiation of luteal phase support is 24 to 72 hours after luteal phase oocyte retrieval. However, it may be depending upon the method of embryo transfer. Oral dydrogesterone might be an alternative and therapeutic option for luteal phase support to improve clinical outcome in IVF pregnancies. So main need is difficulty because they are necessary to enjoy the success, said by Professor APJ Abdul Kalam. And I'm fortunate that Professor APJ Abdul Kalam and me has both got the same award of Dynamic Indian of Millennium by KG Foundation in Coimbatore. Your work is always appreciated because I am there on the GF of so many companies for dydrogesterone. Thank you very much. And at the end, our all patients should be happy. The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here. Thank you very much. I thanks with my two residents.